I want to welcome all of you and thank you for joining us this afternoon. My name is Monique Hardin Cordero, and I am the program manager for the National Kidney Foundation serving Greater New York. And I'm also joined here this afternoon with our community outreach manager, Paige Murray. And of course, we're excited to be hosting. This will be our first virtual patient webinar session for our new fiscal year. And of course, you're going to be in for a wonderful treat. I would say that there's a great deal that's in store from our upcoming presenters. And I would encourage all of you that as we are conducting our session, we encourage all of you to please use the chat feature below and place your or chat if you want to comment, or if you want to send a question, to use the Q&A feature, which is at the bottom of your screen. And with that said, I'm going to use this opportunity to introduce you to our presenter for this afternoon. And he's quite accomplished. So but before I do that, Dr. Palese, can you advance to the agenda slide? Thank you. So just to give all of you who are joining us, we want to give you an idea of how this afternoon is going to unfold. So of course, I'm doing the welcome. That will be followed by our presentation, Q&A, and then we will adjourn. So you can go to the next slide. So this is our presenter for today, and he's quite accomplished. So I certainly don't want to sell him short, but I want to take a moment to share that he is a professor of urology in the Icahn School of Medicine at Mount Sinai. Oh, thank you for that welcome from one of our one of the people joining us. He's also a chairman of the Department of Urology at Mount Sinai downtown and Beth Israel Medical Center. As a chief of minimally invasive urologic surgery for the Mount Sinai health system, he specializes in the diagnosis of treatment of kidney cancer. Kidney ureter, oh my gosh, adrenal, bladder, and prostate disease. There you go. Those were a few tongue twisters. His focus is in the research and treatment of kidney in urethral, and I'm sorry, Dr. Palese, I didn't say that 100%, but urethral cancer with minimally invasive surgery. And he's one of a handful of surgeons in the United States who is fully trained in open, laparoscopic, and robotic surgery. So sorry if I didn't do you full justice, but as you go through your presentation, you can correct me or anything that I said improperly. So with that said, I'm going to turn the presentation over to you, take my face off the screen, and ask all of you who are joining us to enjoy this afternoon's presentation.
Well, thank you so much, Monique. I appreciate your invitation to come here and speak for the National Kidney Foundation, and also Paige, of course, for helping to organize this and making sure that we stay on time and we do our jobs here. I have two of my colleagues with me, my fellow Dr. Joseph Sewell, who is completing his fellowship this year. And those of you who don't know what a fellow is, that is someone who has completed their residency, is now doing an extra year of training to learn another specialty or another subspecialty within what they were trained in. So I am a robotic surgeon. I also do what's called minimally invasive surgery. So the idea that we do surgery through small incisions rather than sort of the traditional open large incisions. We use a lot of technology in what we do, robotic, laparoscopic, and even endoscopic. So we use a lot of laser surgery and such. And so Dr. Sewell has done that. and he's going to be leaving this year to go on out to Long Island and Northwell. So those of you who need his services, he will certainly be out there. And then secondly, I want to introduce Kenny Chin, who is my head of research, who is actually a medical student as well, and will be completing his medical school and interested in doing a urology residency. And so I had the pleasure of having him be my research coordinator for the last year, and he did a phenomenal job. And so he's going to be manning the chat session and taking any questions and sending them our way, either during the presentation or after the presentation. So because we're a relatively small group today, I want to make this relatively informal. So if anyone has any questions, please send them into the chat. Kenny or Dr. Sewell will certainly field them, and then we can answer them even as I'm talking. So I have no problem doing that as well. So to get going here, why don't we sort of start about what this whole presentation is about? Well, we're going to be focusing our talk here about kidney cancer. It also happens to be Men's Health Month, and so one of the things that I want to bring to everyone's attention is, making sure that the men in your life are also getting evaluated for kidney cancer. Kidney cancer tends to affect males more than females, not that it doesn't affect both sexes, but overwhelmingly the majority of people with kidney cancer are almost 2 to 1 male to female. And so, interestingly enough, of all the cancers, when we talk about the top 10, kidney cancer kind of is part of the top 10, but it seems to not get as much attention as some of the other cancers like prostate cancer and breast cancer and lung cancer. And so I think it's important for us to bring attention to it. So why don't we start a little bit with the anatomy? What exactly is a kidney? A kidney obviously is an organ that we have 2 of in our body. They're in our retroperitoneal space, which is in the back area. They tend to help regulate all sorts of things, from certain electrolytes that we take in, like potassium, sodium, and phosphorus, things like that. They also help with regulating blood pressure. They help actually make red blood cells. They emit something called erythropoietin. So they're actually quite important for the physiology of how the body works. So when we break down a little bit what the kidney looks like, there's something called glomeruli, which is made up of something called the renal cortex, which is this area, and the renal medulla, which is this area. So on the kidney itself, when I tell my patients, this is kind of the meter parenchyma of the kidneys here. This is medulla, and this is an area where kidney cancer can form. Now, on the inside of the kidney is an area here called the collecting system, or the renal pelvis. This is where urine is formed, or where when urine gets actually made, it goes into the collecting system, and there's another different area there, a different type of cancer that can form there as well. So when we break these down, the 2 types of cancers we're going to be sort of discussing are what's called renal cell carcinoma and urothelial carcinoma. So renal cell carcinoma, again, it's found in the meat of the parenchyma, sort of on the outside of the kidney, and urothelial carcinoma is really on the inside. It's on the sort of the collecting system where urine is made. Now, the interesting thing, urothelial carcinoma is basically the same type of cancer you find in bladder cancer, and so therefore they're related. Reason being is because the same type of cells that are on the inside of the kidney are also the same type of cells that you find on the inside of the bladder. So the interesting thing is, when we talk about kidney cancer, most people sort of really don't think of more renal cell carcinoma, not the transitional cell carcinoma, which is the one that's on the inside lining. The vast majority of kidney cancers, however, do fall into the renal cell carcinoma range. So I'm going to focus most of my talk on that. But if anyone has any questions about the TCC or transitional cell carcinomas, the ones on the inside, we certainly can address those as well. So what are some of the risk factors for kidney cancer in general? So one of the things that I think a lot of people don't realize is that if you are or have kidney disease, or if you're on dialysis or have chronic renal insufficiency, you are at greater risk for developing kidney cancer, in particular renal cell carcinoma. And so there are reasons to think about monitoring patients who have advanced kidney disease. So meaning that they should probably get ultrasounds or CAT scans in terms of monitoring to make sure that they've not developed renal cell cancer. Smoking. Smoking is a big risk factor for this type of cancer in general. Most people know that smoking causes heart disease, lung disease, and so they're very well aware of that. But do they know that it causes kidney cancer and in fact also causes bladder cancer? And so that's one of the things that we try and educate our patients on. that if they do come in with these diseases, that we have to get them to stop smoking right away as well. Obesity is another one that is a major risk factor. So obviously a healthy lifestyle, low fat diet, more protein, vegetables, things like that is also important to do. So patients that are morbidly obese and have kidney cancer, we'll also try to get them to lose weight and start exercising more. On the same token, their blood pressure is also an important risk factor as well, making sure we keep their blood pressure in check. Like I said before, it's almost a 2-to-1 men to women in terms of who getting kidney cancer. And so therefore, obviously, that's a risk factor being a male. Racial differences as well. African-American men also tend to be more likely to get kidney cancer than other racial groups. And finally, there's of course genetic and hereditary risk factors, and we can talk a little bit more about that in detail as we move forward here. So, question that a lot of my patients will ask is, can kidney cancer be found early? So we know that many kidney cancers are found early, or they can be found early. And a lot of that has to do with the fact that we're using imaging studies in a much larger scale than we ever did before. That means that people are getting CT scans, MRIs, all sorts of imaging studies that they never would do before. They're getting them done because of back pain, or because they're having a GI issue or a gastrointestinal issue. And so we're finding these what are called incidental renal masses or kidney masses that turn out to be kidney cancer. So that you ask, that's a good thing, because we're obviously finding cancer earlier. And as we'll talk a little bit later, finding cancer earlier will lead to more likely that we can avoid metastatic disease and that progression of the disease. There are no recommended screening tests for kidney cancer right now. So from a perspective of community medicine, there is no one test that's always recommended. Oh, everyone should get a CAT scan, everyone should get an MRI, because it doesn't really make sense for lots of different reasons. But where it does make sense is for patients that, for instance, have a familial pattern where a mother has had kidney cancer, a mother and father have had some sort of a renal lesion. Those are patients where probably doing some sort of screening makes sense. So quite often my patients, I'll tell them to, if they have adult aged children, to go ahead and get at least an ultrasound. This is a very low cost test that has a lot of yield. And then if there is something on the ultrasound, we would certainly then go on and use a test like a CT scan or MRI to better define exactly what the problem is. So let's switch gears here a little bit and talk about a little bit of renal cell carcinoma itself, a little bit of the etiology, where it comes from, the histology, what type of renal cell cancers there are, how it presents, and what some of the stages are. Does anyone have any questions up to now? Okay.
I do, Doctor.
Yes.
So why isn't there a recommended test, since we know prevention is a counter cure?
It's a great question. So the reality is that the testing is probably, so there's a certain point where testing the benefit outweighs, or the risk outweighs the benefit, so to speak. And kidney cancer is one of those. There just aren't enough kidney cancers around to justify millions of CAT scans or millions of MRIs being done every year or every 2 years, or whatever that screening test would be. Because it leads to other tests and other things, and we'll talk about that as well. Biopsies, for instance, that in general would not be needed. So there isn't really a good imaging screening test. However, that being said, there will likely be some type of a screening test that we can get in urine or in blood at some point that will be able to screen patients a little bit better, as we do, for instance, with prostate cancer with PSA. That sort of revolutionized the way that we monitor or identify patients who might be at risk for prostate cancer. So it is still, the jury's still in terms of how that's going to happen, but it will happen at some point. Okay, yeah, of course. So let's go move on here about renal cell carcinoma. So again, it predominantly affects men, or more likely affect men, and usually between the 6th and 8th decade of life. So between 60 and 80 is usually where we see a lot of men develop this. That doesn't have to be. I mean, I've diagnosed renal cell carcinoma in 20 and 30-year-olds as well, for lots of different reasons. Again, most of the time we're diagnosing them early stage because they're getting a test done for something else. But what I always say is that cancer starts somewhere. So although we're maybe diagnosing the vast majority in people in their 60s and 70s, there's quite often many that already start showing some lesions already in their 30s and 40s. And so these are the people we want to look for as well. In the United States, we diagnose almost 63,000 new kidney cancers a year. It contributes to about 14,000 deaths in the United States. And that number has been kind of holding steady. It really hasn't gotten much better despite all of the innovations that have been going on. Some of the histology, so the type of renal cell carcinomas that exist, the one that's the most common is something called clear cell carcinoma. That's the one that accounts for almost 85–90% of all kidney cancers. It comes from an area called the proximal convoluted tubule, which is in that meat or that parenchyma that I was talking about of the kidney itself. Another one is known as a papillary renal cell carcinoma. This also comes in that area, the proximal convoluted tubule. Generally tends to also be hereditary and most of the time multifocal, meaning it's found not only in one area, but usually if we have one papillary renal cell carcinoma, we can usually expect to find another one, or if not at that time, at a later date. Another one is called chromophobe renal cell carcinoma, collecting duct carcinoma. And again, these are more rare. These only account for like less than 1% of the kidney cancers that exist. Renal medullary carcinoma, and then there's something called unclassified, which is a cancer that has basically changed so much that the pathologist really can't tell us exactly what it is, but there generally tends to be some type of feature in there that helps define it. So for instance, a feature known as sarcomatoid or rhabdoid. These are unfavorable things to find inside of a kidney cancer, but they do sort of help classify or help define how this cancer is going to act. So the typical or the traditional presentation was something called a triad, which is basically three things that were found. It was the palpable flank mass, so the idea that the doctor could come in and actually feel the kidney mass in your back. That's rare nowadays, mostly because we catch these tumors luckily much earlier than what we used to about 20, 30 years ago. Hematuria, which is blood in the urine. That's also something that can alert us that there may be something going on. So gross hematuria, or blood that you can actually see when you urinate, that always requires a workup for someone to go ahead and work that up. It doesn't mean you have kidney cancer right away, but it certainly means that we have to look for it. And the third thing in the triad is pain. This is where the obstruction occurs, where the tumor is actually pressing on the urine that's being made in the kidney, and that causes pain. And that can occur, all these three things can occur in about 10% of patients, even to this day, although this was much more common, like I said, 20, 30 years ago, when we didn't have as many imaging studies being done on a routine basis, CAT scans and MRIs, and catching these at a much earlier pace. The vast majority, again, are caught incidentally. There are some what are called paraneoplastic syndromes. So when people have kidney cancer, they can develop sort of side effects or other issues. And classically, these are fevers, chills, weight loss, cachexia, things that we see in other cancers and other sort of diseases as well, anemia. And so these are things to look out for, and not that, again, that you have kidney cancer if you have any of these things, but these are sort of flags for us to start looking for something. Okay. The risk of metastases at presentation, the risk of harboring our renal cell carcinoma presentation are also strongly associated with tumor size. So kind of makes sense, right? So the larger the tumor, the more likely we are to find that the tumor has spread to other parts of the body. And so again, it goes back to the fact that if we're going to catch these things, we want to catch them relatively soon, or relatively early in the beginning. So how do we stage these things? Renal cell carcinoma is staged like most other cancers nowadays, which was called the T&M staging, which is tumor, node, and metastases. The T stage for renal cell carcinoma goes again by size. Up to 7 centimeters is considered a stage 1, and so that's pretty interesting, because the tumor can actually get pretty big and still act as like a stage 1 tumor, which has obviously a much more favorable prognosis. Those tumors that get bigger than 7 centimeters become suddenly what are called T2 or stage 2 tumors. And then those tumors that kind of keep growing and go into some of the blood vessels, whether it's into the large blood vessel called the vena cava or into some of the side vessels, can also go into what's called stage 3. And finally, if it goes out of the kidney into the lymph nodes or into surrounding glands or other organs, then it's suddenly a stage 4 or T4. Lymph node status in kidney cancer, basically it's based on whether or not it's there or not there. So if you have any positive lymph node, you would be N1. If there's no positive lymph nodes, N0, and the same what goes for metastases. And again, these are just for staging purposes more than anything else that we look for these things. So just to kind of give you an example what these different stages look like. So a stage 1 tumor can be relatively large, get up to 7 centimeters, and generally it just affects the kidney parenchyma or the meat of the kidney and doesn't get any further in. The stage 2 tumor will kind of start to impinge on different areas of the actual kidney architecture itself. And to give an example, a baseball is about 7 centimeters, a golf ball is about 4 centimeters, and a pea is about 1 centimeter. So up to about 7 centimeters, like I said, is a stage 1. When it gets bigger than this, like more like a softball or even a sort of a volleyball, then we get into the stage 2s and stage 3s. Stage 3 again invades into the veins, while stage 4 starts to invade not only the veins but some of the surrounding organs as well. And obviously the prognosis will change dramatically when we have a later stage renal cell cancer. Some of the familial renal cell cancers, so these are genetically related, or these are cancers that are passed on from family to family. The classic ones, one is called VHL, another one hereditary papillary renal cell carcinoma, hereditary leiomyoma, and Birt-Hogg-Dubé. They're not only associated with renal cell cancer, but they can be associated with other things as well. I'm mentioning them because we do have patients that fall into these categories, and so they obviously would also be treated for the kidney cancer like anyone else, but based on sort of what their symptoms and at the presentation we find them. So let's break this down a little bit more into the 5-year survival rates for kidney cancer, for renal cell carcinoma in particular. So stage 1, again, this is the tumor that grows can be up to 7 centimeters. If we catch it, if we do surgery in general, and we treat it, you have a survival rate of 93% or better. Okay, so that's the good thing. So if we catch these things early and we treat them early enough, we have more than a 90% survival rate in the first 5 years. When we start getting to stage 2 and stage 3, these numbers start to go down a bit into the 70 percentile, and of course, the stage 4 metastatic tumors goes down, as do most metastatic or late stage cancers. We tend to see a poor survival rate over time. Now, I'm saying that a little bit of a grain of salt, since there have been some real improvements in our adjuvant therapies now, especially with immunotherapy. We're going to talk briefly about that as well at the end of the presentation. But like I said, this 14% is probably going to change more and more over time as we continue to see more and more improvements. So again, we talked about how is kidney cancer diagnosed. Well, most of the time we find these with looking at an imaging study. The classic imaging study that we recommend is a CT scan or a CAT scan that has radiation. It definitely requires some type of a dye. So contrast dye is usually the best way to identify it. The CT scan will tell us exactly where the tumor is. It'll help define the anatomy. If not a CAT scan, an MRI or magnetic resonance imaging, this does not carry radiation. But again, contrast is also needed, and a lot of it depends on also if a patient is able to get that. So our patients with renal insufficiency or poor kidney function, we have to be careful with giving them dyes. If they're on dialysis, then giving a dye is less of an issue. Ultimately, a good screening test or good screening tool, we talked about as an ultrasound, not as sensitive as a CT scan and an MRI, but it's a good screening tool, meaning we can use it to identify whether someone has kidney cancer and then go on and do some more refined testing if necessary. So what about a biopsy? So a lot of my patients will come in and ask, well, I've got this kidney tumor. Why don't we go ahead and take a piece of it? So there are reasons to do that in a lot of different types of cancer. Now, kidney cancer is one of those cancers that is slightly different. And the reason being is because the biopsy may not necessarily change what we're going to do, meaning that if we see a kidney mass, in general, the first line of therapy is to remove it. So it is very much a surgical disease, especially in the early stage cancers or early stages of kidney cancer. And so doing a biopsy isn't really necessary since it's not going to change what we're doing. There is also a theoretical risk that if you biopsy a patient that you could seed them. Now that's a very theoretical risk. There's very few cases that have ever happened where someone has been biopsied and suddenly develops cancer along where the biopsy tract is. But it is not zero. It actually has happened. It has been confirmed in some cases, but it's a very, very low risk. And the biopsy may be important or can be important if, for instance, we don't want to do surgery, or we don't think it's a primary kidney cancer. If we think, for instance, a metastatic or a different type of cancer than kidney cancer. So, for instance, something called lymphoma can sometimes show up in the kidney, and it has a very distinct appearance on the imaging studies, and it may make sense to go ahead and do a biopsy at that point. So we'll talk a little bit more about what in terms of the biopsies. We'll talk about indications, the accuracy, and what are some of the limitations. So historically, like I said, we reserve the renal mass biopsy for evaluation of metastatic disease or looking for an abscess or lymphoma. But again, in patients that aren't going to do well with a potential surgery, or they have other reasons why they can't get surgery so well, so patients who are more elderly and frail, we may be able to avoid doing surgery or putting them through a bigger procedure by doing the biopsy at that point. It can also be used for, looking at whether or not someone is an acceptable operative candidate for resectable localized tumors. It can also be used for another area called ablation or active surveillance. So if, for instance, we don't want to do surgery, but we want to, for instance, freeze the tumor, we can put a little needle into it and freeze it, or burn off the tumor, especially if it's small enough. I'll talk a little bit more detail about that on a few slides. Then there's also something called active surveillance, where, for instance, someone is also elderly, let's say they're in their 80s, 85, have had a heart attack, and may not be great candidates for surgery, and their tumor is relatively small, 2 or 3 centimeters. They may be great candidates for active surveillance. And so again, these are patients that we would monitor and watch on a regular basis, whether it's once every 6 months to a year with an imaging study and maybe a biopsy to determine if we need to do something over time. The accuracy rates for biopsies also are very variable. Recently, with newer technology, we've seen rates approaching 90% or more, with improved sensitivity and specificity. So meaning that we're more confident that the specimen that we get back is really the specimen that we're reading. The complication rates have also gotten much better as people have gotten better. There's the theoretical risk of tract seeding, like I talked about, it's extremely rare. And there's, of course, also a low false negative rate. So it can be performed safely in the right hands and with the right techniques. So there have been studies that look at this. I sort of want to show your attention at the end of this this kind of series here, showing the complication rates. And so it's not zero, these complication rates. I mean, some studies have shown 0%, others have shown as high as 8.5%. And again, this is one of the larger studies from Richard and al. They looked at 529 patients, and almost 8.5% of patients had some kind of complication. So it's not without its issues, depending on who's doing it and where it's being done. Some of the limitations of doing a renal mass biopsy, there could be an underestimation or an inability to differentiate whether it's a low grade or a high grade type of tumor, which could be important for whether or not you want to actually do a biopsy. There's an inability to actually stratify the prognosis of the patient. So whether or not this cancer is a cancer that's going to progress and actually cause the patient to actually die from the cancer. And so one of the things is for the future of this is there may be a way to do this with molecular information, so genetic testing, to actually see if we get a piece of tissue back, and we can then sort of molecularly evaluate the tumor. Will this become a tumor that we have to worry about? Will this be a tumor that we don't have to worry about? That may also change in the future how we do this. Maybe everyone's going to get a biopsy at some point, and then we'll avoid many more surgeries down the line. Briefly talked about a little bit of active surveillance. So active surveillance is when we monitor small kidney tumors, mostly because we believe that they're benign, not tumors that are going to potentially metastasize, or if the tumors are very small and we have patients that are not great candidates for surgery, like we talked about, we may be able to monitor them on a regular basis with imaging studies such as ultrasound, CT, or MRI. Now, the important thing here is to monitor them on a regular basis. And basically that means, once every 3, 6, 12 months, the latest, and until we get to a point where we may have to then proceed. Some of the indications, like I said, the absolute indications, a patient in whom ablation or surgery poses an unacceptable mortality risk, so patients that are very sick and elderly who just won't do well with the surgery or procedure, probably should go on active surveillance if that's appropriate for them. There's also the relative risk if someone has another active malignancy. They also are not, they would need potential for renal replacement, meaning that if we do surgery or we do a procedure, it would cause them to go on dialysis. This may also be a reason to not necessarily do surgery, but then put patients on active surveillance. And then there's also the elective side, which are patients who are otherwise healthy, but the risk factor for this being metastatic disease is pretty low. And so we'll take that chance to put them on the active surveillance. There's different protocols. How do you do that? Again, like I said before, it's just a question of finding sort of a regular interval of how often you do it, whether it's every 3 months, every 6 months, every 12 months. We also want to look at the size of the tumors over time. You know, if the tumor grows faster, most of the time that starts to push our reasons for recommending surgery or intervention at that point. But it doesn't have to be, meaning that tumors can also stay stagnant and then one day start to grow very quickly over a short period of time. And so that's why it's important to have these regular intervals over time as well. The natural history of a kidney tumor is to basically grow about 1 to 2 millimeters up to 5 to 7 millimeters a year. A fast-growing tumor will grow about 10 millimeters a year or 1 centimeter. So that that's a considered a very aggressive one. Most of these tumors, like I said, they'll grow maybe at 3 to 5 millimeters at the most. And so we keep that in mind also as we're monitoring patients with active surveillance. And so the number of active surveillance patients, there's quite a few studies that have been done in the past. And so I'm also direct you again to the end table here, looking at new metastases. So patients that are on active surveillance, how many of them will actually suddenly show up one day with metastases? Well, if they're screened, still even up to 3.2%, depending on the study, will show up with metastases. So it's not totally without its risks that if someone goes on active surveillance that they won't develop metastases. On average, as we say, when I usually counsel my patients, about 2% that patients over time will show metastatic disease. And so therefore, based on the size of the lesion, we'll determine whether or not we go ahead and recommend surgery. So metastatic lesions, or the likelihood of developing metastatic lesions, does start to go up as the tumor size goes up. We generally quote 3 centimeters being that sort of cutoff. That's pretty a pretty conservative number. It can happen when they're a little bit smaller than 3 centimeters, but it's very, very rare. And so 3 centimeters is not a bad sort of marker that we use. And again, if we monitor patients and we have someone on active surveillance, patients active surveillance, and we start to see that the lesion starts to grow over time, this might be a reason for us then to intervene, to actually then recommend either going ahead and doing surgery, whether it's a nephrectomy or a partial nephrectomy or an ablation. And so therefore that it's important, like I said, to keep a short leash on patients as we monitor them. Let's move on here. So let's look at some of the treatments. And before I start, does any other questions, anything else come up, guys? Kenny, anything in the chat that we want to sort of bring up right now? Okay, can you go ahead and unmute yourself and come on in?
Yep, so Dr. Puisi, you have some questions. What alternative imaging other than CT scan can be done if insurance cannot cover the CT scan?
Okay, great question. Yeah, so this is a big issue we usually have with insurance companies. So their intent is to block anything that a doctor prescribes, especially if there's sort of an interval that they decide that that's not a long enough interval to get studies. So CAT scan is one of the preferable imaging studies. MRI, which tends to be a little bit more expensive. So usually if they're not going to cover CT scans, they probably won't cover the MRI either, although I've seen that they do sometimes. So it's still worth at least trying. We talked before that an ultrasound is not a bad study to use as a screening tool, not a great study to look at progression of disease. So not a great study to actually identify if a tumor is growing rapidly or changing. But that being said, you can use ultrasound, for instance, if you've got a cyst or an abscess or a solid lesion, then the ultrasound can definitely help with that. And so, there is a certain amount of information you get from there. If there's nothing else, meaning that everything else is being blocked by the insurance companies, an ultrasound is a relatively cheap test that you can still pay out of pocket. And some places you can do it under $100, $150. And so I think it's worth doing if it really comes down to it.
Another question by Raisha Castro. How will we know if the cancer has come back? What should I watch out for? What should a patient watch out for?
So that goes back to, again, making sure we monitor patients over time on a regular interval. So I was going to talk about this a little bit later, but in terms of so for instance, if you've had kidney cancer, you've undergone surgery. Let's say it was a stage 2 cancer, so the tumor was over 7 centimeters. What we would do is we would monitor you on a regular basis with imaging studies, CAT scans and MRIs in particular, and see you regularly. That's the important thing with all these cancers, is having a regular interval where you're seeing somebody and getting these imaging studies every 3 months, every 6 months, every year. So I have a protocol where patients come in, at the very least, we see them every 6 months. We get them imaged every 6 months for the first 2 years. After 2 years, if everything looks good, we'll then go to once a year. And then usually I'll do that lifelong. Okay, so even if someone has had kidney cancer 20 years ago, I generally recommend some type of imaging study during that period of time. It doesn't always have to be a CAT scan, doesn't always have to be an MRI, but at the very least, maybe an ultrasound to monitor them over time.
Doctor, two more questions. Why, Monique has asked, why is kidney cancer more common in men than women?
Great question. Probably there's a certain, there may be something that just obviously is genetically related, but probably a lot to do with lifestyle as well. Men tend to be a little more obese than women. They tend to have higher blood pressures. Their diets are worse than women. They smoke more. So all those kind of reasons that probably might be part of what's going on here.
And another very good question by Raisha Castro that I think we can answer. And the question is, can you have kidney transplant while you have kidney cancer?
So that's a great question. So actually, Kenny Chin and myself and my team, we've been helping the kidney transplant team at Mount Sinai develop protocols as to how quickly someone with a cancer, for instance, renal cancer or kidney cancer, how quickly can they get on the kidney transplant list? Because obviously a lot of our patients who require kidney transplants or have end-stage renal disease may have had either a kidney cancer that required a surgery, or they're on dialysis and suddenly develop a new tumor or a small tumor that has to be removed. And so how quickly can we get them onto the transplant list again? And so that's a very very controversial area. We're trying to define that as best we can. Traditionally, it was a 2-year wait list that you had to be cancer-free. So if you had, let's say you were on dialysis for 6 years, and one day we discovered that you have a kidney lesion on your kidney, it's 4 or 5 centimeters. It gets removed. You're still a stage 1. The first year goes by, everything is clean. You're getting your imaging studies, your CAT scan, your MRI. And there's no recurrence of kidney cancer, yet the transplant team would refuse to do a surgery until you hit the 2-year mark. And that was always a hard and fast sort of a blockage there. That has changed again as we've become better at understanding the prognosis of certain kidney cancers, the prognosis of low-grade cancers versus high-grade cancers. And so it really depends on the center. Like I said, at Mount Sinai, we're trying very hard to make it easier for patients to get on the transplant list and to get a transplant without having to wait that requisite minimum 2 years, especially if they have a cancer. Kenny, you want to add anything? Or?
Yeah, Dr. Polisi, I think on our practice, when we, patients ask us about active surveillance, they're usually wondering, well, if I go into like these schedules, when is it a good time to act, or when am I at risk that something else may happen?
Well, so I mean, the risk that something's going to happen, it's never zero, right? Once you have a cancer, you're always going to be sort of in a protocol where we have to monitor you, and so I think it's important that you continue to be seen regularly. And if you're going to be on some type of an immunosuppressive drug, especially as a transplant patient, even more of a reason we should monitor you on a regular basis and keep a close eye on you. Okay, anything else, guys? That's it. Let's talk a little bit about some of the treatments, okay? So one of the treatments for what we call localized kidney cancer or localized RCC. So these are tumors, again, that are stage 1, stage 2, maybe some stage 3. So these are tumors that have not grown out of the kidney, that are still very much inside the kidney, one form or another. Usually, like I said, we know that based on certain imaging studies like CT scans, MRIs. failed to mention PET scans is another sort of imaging modality that sometimes we use. It specifically looks to see if there's what we call the heat pattern, whether there's any kind of activity or cancer activity in certain areas. That can sometimes be helpful in renal cell cancer to see if the cancer's gotten into the other areas or other body parts. Traditionally, the kidney cancer or renal cell carcinoma is a surgical disease, meaning that the first line of treatment is get it out. So we would remove it either through what's called a partial nephrectomy, where we go ahead and just cut the tumor out and leave the kidney behind, or we take the whole kidney. It's called a radical nephrectomy. We can also do something called an ablation, what we talked about, whether it's cold or heat. We can literally burn off the tumor, and then something called adjuvant therapy, which is sort of some type of a drug, whether it's an immunotherapy or chemotherapy that can be given, and we'll talk a little bit about that as well. So traditionally, surgery was always open. So you would go in, you would then make an incision inside the patient. We would then cut out the tumor or take out the entire kidney itself. Now, partial nephrectomy, which is just, again, removing the tumor, that is a relatively new concept. Only in the last 25 years that become sort of a recognized and also not only recognized treatment, but also really the mainstay treatment for kidney cancer, especially for stage 1s and even stage 2s. And the thought is that patients will do better if we have more kidney function over time. Obviously, we don't want to risk them getting a recurrence in their kidney cancer. And so we have to weigh the pluses and minuses of removing the whole kidney versus not removing the whole kidney. Now, removing the kidney completely, that was sort of the mainstay therapy 25 years ago, even for small tumors. And patients still did very well when we did that. It's just that they would potentially be more at higher risk for developing some renal failure or renal insufficiency over time, especially if they have risk factors. Like, for instance, if we operate on diabetics or patients with high blood pressure, we preferentially want to do something that will preserve kidney function because they're more at risk for losing their kidneys over time. So partial nephrectomy can be done, as we just talked about, open. The modern era, about 20 years ago, we started doing them laparoscopically. I was trained in that 20 years ago. Still do this procedure when it calls for it. But the newest, or sort of what's become now the standard of care, is to do these robotically. And I'm going to show us a little bit of video a little bit later on how that works. But again, it's the idea that we're removing the tumor, keeping what's called a negative surgical margin. We're leaving a little bit of healthy sliver of regular or healthy tissue around the tumor, so that everything that we have left inside the kidney is not cancer. We've got what's called a negative margin. And then we want to reconstruct the kidney. We want to basically close the kidney, put some glue on it in some instances, so that it doesn't leak or doesn't bleed afterwards as well. Okay. Partial nephrectomy is actually sort of an imperative, or really an important tool to use in the setting where someone has a solitary kidney or one kidney, or bilateral tumors, so tumors that are on both sides of the kidneys, or patients, again, with advanced chronic disease who may require dialysis, and we want to avoid them going to dialysis. We would then go ahead and recommend a partial nephrectomy. It's basically an elective procedure in patients with normal kidney function and normal contralateral kidney. It's highly recommended if it can be done safely in most patients. But there are times where doing a partial nephrectomy may not make sense, because there are certain reasons why a radical nephrectomy might be a safer option. So partial nephrectomy does have a slightly higher complication rates. And so we'll talk about that, why maybe, for instance, if an elderly patient is 80, 85 years old with otherwise normal kidney function, why a radical nephrectomy might make more sense in those situations. So as we discussed before, for healthy patients, the partial nephrectomy is the standard of care, especially for stage 1A renal masses. These are tumors up to 4 centimeters, and basically any patient or any tumor that is something that where we can preserve the main function, is important that we do that. For patients with major comorbidities, increased surgical risk, partial nephrectomy should be considered, but again, radical nephrectomy may be the treatment of choice. There are certainly anatomic considerations why we want to do a partial nephrectomy versus not, and why we want to do something open versus robotic versus laparoscopic, and all these are sort of factors that come into play when we're making a lot of these decisions. One of the things that we do when we're doing a partial nephrectomy is we have to stop the blood flow to the kidney. So we literally have to put a sort of a clamp on the artery during the operation. And so the ideal time, or the amount of time that the kidney shouldn't have any blood flows is less than 25, 30 minutes. And so that's also a factor when we get into doing these types of procedures. We want to make sure that we can safely do that. If we don't think that the surgery is going to be done safely under 30 minutes, or removal of the tumor is going to be able to be done in less than 30 minutes, that might be a reason why you may not want to pursue the tumor that way. We try and get around that by doing something called cold ischemia. Sometimes we'll put the kidney in actually an ice bath to kind of slow down the process a little bit, create some preservation, and that does help in certain instances and can be useful in certain kinds of cases as well. So radical nephrectomy, again, that's the removal of the entire kidney. It used to be we would also include the adrenal gland and all the surrounding tissue. Nowadays, we just remove the kidney and the tumor itself. Again, makes sense for larger tumors or patients that are not good candidates for partial nephrectomy. Like I indicated before, the complication rates tend to be a little bit lower with radical nephrectomy. The postoperative hemorrhage or bleeding is about half of what it is for partial nephrectomy. So radical nephrectomy, all comers, is about a 1.2% risk that there could be some postoperative bleeding. It's close to 3.1% in partial nephrectomies. Because we're cutting into a kidney for partial, there can be what's called a urinary leak, where people actually spill urine into their bodies. That happens in about 4 to 5% of patients. It really shouldn't happen with a radical because we're taking the whole kidney. And then reoperation, or the reasons for having to go back in afterwards, it's about twofold with a partial nephrectomy, so about 4.4% versus 2.4%. So again, these are factors that I take into account as a surgeon when I look at patients and I decide what the risk reward ratio is. So the adrenal gland, so this is a portion of the kidney, or it's not really a kidney, it's actually a gland that's on top of the kidney. And it used to be traditionally removed at the time of a nephrectomy. Nowadays, we generally leave the adrenal gland behind. It's important for certain hormone regulations and also for helping with testosterone production and also sodium regulation, things like that. So if we don't need to take the adrenal gland, we generally recommend leaving it behind. There are instances where it is favorable to take, and that's for like late stage cancers where the tumor looks like it's starting to invade into that area as well. Lymph nodes, sometimes we remove lymph nodes, sometimes we won't. Lymph node removal doesn't really help with long-term survival, but it does help with staging purposes, and so therefore there's reasons to take that as well. So again, this is a quick little video and showing how the robotic surgery works. This is what we call a multi-port procedure. We're putting a bunch of robotic arms into the body. Here we're showing how the artery is being then cut off, putting a bunch of clips on the artery. This is the kidney over here. This is showing the tumor on this side over here. And on top is the adrenal gland that we talked about that generally sits on top of a kidney, and that would generally not be taken out if necessary. So what we've done is we've now clipped the arteries, we've clipped the vein, we've actually ligated or cut this apart. And so, obviously this is a cartoon rather than the real thing. Part of the reason is because I didn't want to get anyone to get too grossed out by all this. So we sort of, and this kind of demonstrates exactly what we're doing. So the artery's been taken, the vein's been taken, and here now we're clipping the ureter. The ureter, again, is the tube that connects the kidney down to the bladder. This is where urine flows. So we obviously want to make sure that's clipped as well, that we don't have what's called a urine leak. So here we're cutting that as well with our robotic scissors. And then the final portion of this is we then basically take off the whole adrenal gland, the top portion of the kidney there as well. Okay. Once the kidney has been completely secured, it's now clipped, both the artery, the vein, and the ureter have been clipped. We'll generally put the kidney into a bag so we don't spread any tumor cells around, and that's how we get it out of the body at that point. Okay, so that's what's called the multi-port system. We now have even gotten even further and more fancy, called single-port systems. The idea that we're doing everything through basically one small incision. So this is kind of the latest and greatest of surgical technology. And we've been lucky enough that we have a couple of these at Mount Sinai, and so we've been doing quite a few operations with them. In particular, I've been using it for some surgery called donor nephrectomy. So patients that donate kidneys, we're taking them out through one small incision. So generally through like a C-section scar. So that's also cosmetically is a little more appealing to a lot of patients. And so this is kind of what it looks like. We have one sort of trocar, one area that goes in. I, as a surgeon, control all the different sort of arms. It almost looks like a snake coming into the body. So we have a camera. We have then three separate arms that we use to control. I have foot pedals that I can decide whether I need to move around or cauterize or sew things. And so that's actually the nice thing about this technology. And it's really, every year we get some new technology advancements, and this is kind of a neat new toy and new tool really that I can use, which is great. So, I think we're almost nearing sort of close to the end here. I'm just going to kind of skip ahead a little bit here. So we talked a little bit about ablation, which is an alternative to the traditional surgery, which is open laparoscopic or robotic. So the idea that maybe someone is not a great candidate for actually going in and removing the tumor itself, we want to sort of put a little a needle in there, which we can then freeze or burn off the tumor. And so that's an important thing to know, and is available for certain patients. There's also adjuvant therapy. So this is different than neoadjuvant therapy. So neoadjuvant therapy is when we give some type of therapy before surgery. Adjuvant therapy is something that's given after surgery. So there are definitely different types of drugs that have been given in the past. Most of the time, they don't seem to help too much, or the traditional ones didn't help too much. The newer class of immunotherapies, mTOR inhibitors, VEGF inhibitors, these are definitely making big changes in what's happening right now. Okay, so with that, I think I'm going to sort of then skip to the very end here. I'm not going to talk about metastatic disease because that's a whole lecture by itself. Just want to follow up and state at the end here that the follow-up after treatment, again, we talked a little bit about that. Once you've been diagnosed with kidney cancer, once you've actually gone through surgery or treatment, it's important to then follow up regularly with your doctor to kind of make sure that you're getting all the regular imaging studies that you want, whether it's the CAT scan, the MRI, the ultrasound, and that we monitor you on a regular basis. Like I said, on my patients, I generally tend to see them lifelong. It is acceptable at a certain amount of period not to have to go every year, but in general, I do recommend that it does make sense to be seen every year. And the final component is this: we always want to make sure that the mental health of our patients is taken care of. Any kind of cancer can take a tremendous toll on patients' mental health, and so it's always important to make sure that you have a good lifeline and a good support group. There are support groups that exist for all cancers, particularly renal cell cancer, prostate cancer, and many of the other major ones. We're fortunate enough in New York City that exists to a very large degree, and there are a lot of, like I said, a lot of support groups out there. But it's not uncommon, especially if you're suffering or have been treated for cancer, that you suffer anxiety, depression, and stress related to it. That's all normal, and there has to be a coping mechanism as well. All right, so with that, I want to say thank you to everyone, and I probably we'll take the time now to take some questions and answers. Joe, Kenny, anything that's come up that we want to sort of discuss?
I know you touched on ablation for kidney cancer and surgery as well, and mentioned that surgery is the first line of therapy, but can you maybe elaborate a little bit more? Why is it that ablation is reserved for those patients that aren't surgical candidates, and it's more like a second line of treatment?
Sure. So when it first came out, when ablation first came out, so I was just starting out as a new attending, and so there was a lot of fanfare behind avoiding surgery altogether and just going ahead and putting a sort of a needle into these tumors, freezing them. So you create a cycle where you freeze thaw, it's called. So you basically freeze the tumor, you thaw it out, and then you freeze it again. And so when you do that, you split open all the cells and you create sort of inflammation. And the thought was the body would just chew up those cells and we would kill the cancer and avoid a big incision, and patients would do well. And so, it had promise, no question, especially for smaller tumors. But what we did see a long term, it was never as good as doing a partial or as doing a radical. So we would have higher recurrence rates over time. So where, for instance, a 5-year survival for T1 partial or radical nephrectomy is about 93%. In ablated tumors, it's closer to 83, 84%. So still pretty good, but not as good as doing it the traditional way. So that is probably the mainstay reason why it's not being used for on a regular basis. That being said, it can be used for tumors that are still very small. Less than 3 centimeters is generally the cutoff. Many of our colleagues in interventional radiology do this, and then we will send patients to them to have this particular procedure done in the right group. You can do it under laparoscopic or robotic vision as well, where I go in and I would actually identify the exact area where I want to go, and then freeze that area. But then you have to weigh the pluses and minuses while you're freezing. If I'm already there, I'm already seeing the tumor, why not just remove it? Partial nephrectomy has become very standard. We can do this operation in an hour, hour and a half. Patients go home the very next day, and so you want to weigh the risks and benefits as to why you're not offering the better surgery of the two.
We had a question from Raisha Castro. I believe this question was asked during the discussion of partial nephrectomy. And she asked, and I'll paraphrase, whether or not partial nephrectomy is considered in pediatric cases of renal cancer.
Great question. So pediatric cancers, that's a whole other ballgame. They traditionally don't really form along the same lines of in the adult line. Quite often we're talking about things like Wilms tumors, nephroblastomas. These tend to be a lot more aggressive. They also tend to be tumors that if they're not taken care of right away, they can become issues down the line. It's not to say that partial nephrectomies won't be done in pediatric cases, but in general, depending on what the tumor is, radical nephrectomy is really the preferred method, because you like I said, you have a lot of times one shot or one good shot to really eradicate the tumor, and so you don't want to give that shot up.
I have a quick question, Dr. Polizzi. Kidney cancer, I guess similar to CKD, are there any signs that you might try to be aware of so that you can monitor yourself?
Yes and no. Unfortunately, kidney cancer is if you have symptoms, meaning that for instance, you're passing blood or you're having pain, in general, that's probably not a good sign, because probably the kidney cancer has developed to a level where those symptoms are now evident. And so that usually implies that there's a larger tumor. So in the ideal situation, you actually don't know you have it, and it's just picked up incidentally by either some imaging study, or you've gone out of your way to evaluate yourself because of whether you have a family member or someone that's prompted you to do that. So there like I said, there really isn't a good sort of symptom, like having a cold or a fever or chills. There is nothing really you can pinpoint in that regard. In the future, hopefully there'll be some markers, some tumor markers that we can identify, that whether, like I said, whether it's in the urine or in the blood. And preferably something like urine would be great, where you just urinate into a cup and you go to the doctor and he or she says, "Oh, look, this is popping up, this marker's popping up, so let's send you for a test for kidney cancer." That would be the ideal situation, and that's not so far-fetched. That I think is around the corner. If not in the next 5 years, certainly by the next 10 years, we should have something.
Okay, very good. That's good to hear. Are there any other questions, comments? If not, I guess the last slide after this is probably thank you, if I'm not mistaken.
Sure is.
So with that said, I want to thank your team for coming on this afternoon and dropping pearls of wisdom regarding this particular condition. Once again, we want to share information so that we can educate and empower our patients. And you certainly did just that. You gave us a lot of food for thought and education this afternoon. So once again, I want to thank you, Dr. Polizzi, and your team for coming out and educating all of us. And the women in the audience, please share this information with your significant other, friend, brother, son, father. Please make sure you share this information so that we can stay on top of this important issue. So with that said,